It's a great pleasure to be back here at MSA New Jersey. I think this is my third or fourth year. It's great to see familiar faces, and it's also nice to see new faces. It's a great organization, and there's plenty of support in the room. So we're going to begin, Dr. Palma and I, by giving you a little bit of an overview of what is MSA. We're going to talk about some of the research we're doing and some of the clinical trial opportunities, so you'll get a flavor for what's going on. So what is multiple system atrophy? Multiple system atrophy is what we call a sporadic disease. As far as we know, aside from some very rare cases in Japan, there's no hereditary inheritance of the disease. It's not particularly linked to an ethnic group. There's no male-female predominance. So it's what we call a sporadic disease. It's an adult onset disease, so typically the age of onset will be in the mid-50s. It can be a little younger, it can be a little bit older, but if we put the entire population together, it's around the mid-50s. It's a neurodegenerative disease, which means the problems that you have in MSA are caused by loss of nerves or loss of the cells that support the nerves within the brain and the spinal cord. And it progressively affects movement and balance and autonomic functions. Now, autonomic functions, which are close to our hearts, because that's what we study, are the automatic functions of the body. They're the things you don't really think about. They're the things like your blood pressure control and your heart rate, your gastrointestinal motility, urination, sexual function, sweating, and breathing. So what causes MSA? We've advanced quite a bit in what we know what causes MSA. We don't know why this happens, but we know that what happens in MSA is you have these nerves, right? And nerves are just cables that send electrical signals from one place to the other and communicate in how you should move or how you should do. So it's like the conduction, right? And these nerve axons that transmit the message are wrapped around with something called myelin, which is like if you imagine you have a cable, you have a wire inside, and then you usually have the plastic around the wire that provides the insulation. In the nerves, this is called myelin, and they provide the insulation. They support the nerves. They're critical for the nerve function. And in multiple system atrophy, these oligodendrocytes are the main target. These supporting cells that get progressively hurt or injured over time, and they're the cells that are providing support to the neurons. So these oligodendrocytes, these ones that provide the insulation to the nerves, they fill up with clumps of misfolded protein, right? And the protein, you're going to hear this quite a bit, right, in your journey with MSA. The protein that is heavily involved in MSA is a protein called alpha-synuclein. It's the same protein that's involved in Parkinson's disease. It's the same protein that's involved in dementia with Lewy bodies. So it's a well-known protein to cause neurodegenerative diseases. The difference is really in MSA, it tends to target those oligodendroglial cells, those insulating cells of the nerves. It's 140 amino acid protein, and it's produced normally by all cells of the nervous system. We don't fully know the function of this protein, but what we do know is for some reason it kind of, proteins are constantly folding and misfolding. And what happens in multiple system atrophy is this protein misfolds in a weird way, and it causes other proteins to misfold in a weird way too. And those proteins clump together, and they clump together inside those supporting cells, which eventually die off over time, which affects the nerve fibers themselves. So that's the neurobiology of MSA in a nutshell, right? So you're going to hear alpha-synuclein. The only thing you need to know is that's that rogue protein that accumulates and clumps together. So we're going to talk now about how MSA is diagnosed, and I'm going to turn the podium over to Dr. Palma, who's an expert in this.
Thank you so much. Well, good morning, everyone. My name is Alberto Palma. I'm one of the neurologists at the NYU Dysautonomia Center. We are possibly the most comprehensive MSA center in the East Coast in the United States, right? So that's why some of the patients here already know us, and eventually every patient with MSA in the East Coast sees us at least once, right? So I'm very glad to be here. It's my first time here, and I hope we're gonna keep seeing each other in following years, right? So Lucy just made a great summary of what we know about the cause of MSA. Let me go over now a little bit of how doctors can diagnose MSA, right? So as I was telling before to some of the people, to have a confirmed diagnosis of MSA, we really need to take a chunk of the brain of patients, right? And that's something we don't really do usually, right? For obvious reasons. So this is done at autopsy after the patient has died. We take a look at the microscope and we can see these changes that Lucy was talking about. We can absolutely see them at the microscope, and we can determine whether this patient had MSA or something else. But before that happens, we really need to have as accurate as a diagnosis as we can, right? And for that, what we use is consensus criteria, which is just a number of checklists, right? So if this patient has these, and that, it looks like probable MSA, right? Or if this patient has these other things, he looks more like probable CBD, right? So what is the checklist for MSA is the one I put here, right? So to have a diagnosis of probable MSA, you need at least two of the three things I mentioned there, right? So you definitely need to have autonomic dysfunction, meaning problems in the autonomic nervous system. The autonomic nervous system is a system in your body that controls automatic functions, right? That's why our presenter kept saying automatic. It wasn't that wrong, you know? It's the automatic functions of your body, meaning blood pressure regulation, bladder problems, problems in the gastrointestinal motility. So to diagnose MSA, you must have that. The patient must have that, must have bladder problems and or blood pressure problems and or some other autonomic problems. So that's a must. And then you need to have another one, either of those, right? So you need to have a movement disorder that looks very much like Parkinson's disease, but can be maybe a little faster and maybe not responding very well to the usual medications that we give for Parkinson's, like levodopa. So if a patient has those two, the autonomic dysfunction and a Parkinsonian syndrome, that's it. That's the criteria for probable MSA. Or the patient can have the other type of movement disorder, which is a cerebellar syndrome. This is slightly different to Parkinsonism. The cerebellar is most like a wide-base walk, like if people who are drunk walk a little bit, right? Like an inebriated gait, and then the slur speech, right? When this happens, this type of movement disorder is what we call a cerebellar syndrome. You can be diagnosed with probable MSA if you have the autonomic dysfunction and the cerebellar syndrome. And that's why you may have heard that there are two phenotypes of MSA. We have the MSA Parkinsonian, and that's when patients present with something looking like Parkinson's, or you have the MSA cerebellar, the MSA-C, which is when patients present with something that looks like a cerebellar syndrome. But you definitely need the autonomic problems. If you don't have autonomic problems, by definition, you don't have MSA. Then we have another bunch of tests that we can use sort of to support the diagnosis. They are not required in the checklist that I mentioned, but it's interesting to have them because if you find specific signals or specific findings, they can support the diagnosis of MSA, right? One, the most common is brain MRI, and I'll show you an example of a brain MRI in a patient with MSA in the next slide. Then you have something that people are more interested each time over the years, which is a smell test, right? Why? Because when we check your smell, olfaction is normal in people with MSA, but is very reduced in Parkinson's disease. So it's a simple way of saying, well, this looks more like MSA, this looks more like Parkinson's disease, right? Then most patients with MSA undergo a sleep study, and this is to rule out sleep apneas, to diagnose insomnia, or to diagnose something that we call REM sleep behavior disorder, which is something very peculiar, which is basically speaking and acting out or yelling during dreams, right? So when we dream, when we are sleeping and dreaming, we should be completely paralyzed, right? And healthy people are completely paralyzed, except for the breathing muscles, of course. But people with this REM behavior disorder, they are not paralyzed, and when they are dreaming, they act out their dreams. So if they are dreaming that they are fighting while they are dreaming. If they are dreaming that they are running, they do that. We'll have time for Q&A at the end. Perfect. Then we can do autonomic testing to confirm that there is autonomic dysfunction. And then we can do a number of bladder urology testing to confirm that there is a certain degree of bladder dysfunction. Let me show you an example of brain MRI in a patient with MSA. There are many different typical findings, right? The most common one, or the one you'll see in any textbook, is this little thing in here. You know what this is. This is a brain MRI, and this is a section of the brain like this, like axial, right? So the patient we are looking at the patient from let's say from below. So this is the right side, this is the red side, the left side, this is the nose, right? These are the right cheek of the patient, the left cheek of the patient, and this is the brain, right? So here there is an area of the brain called the brainstem, and you'll see here that there is this is like a little bit augmented here, right? So you see that there is a cross in the brainstem, sort of like a cross, and this is what we call the hot cross band sign, right? So when you see that in a brain MRI, that has a lot of chances to be MSA. What is the problem with this? The problem with this is that it shows up when the disease is relatively advanced, right? So most frequently, we already suspect a patient has MSA, and then when we do the brain MRI and that shows up, we say, okay, that supports our previous diagnosis of MSA. This usually doesn't show up in the early stages, which is when the diagnosis can be a little trickier, right? So, but nevertheless, when you see that in a patient whom you suspect has MSA, it's supporting your suspicion, right? Then another problem is that because MSA has so many different presentations, doctors and nurses who are not familiar with MSA can take a while to reach a correct diagnosis, right? And why is this? Well, it's because for patients that present with Parkinson's-like symptoms, they usually are misdiagnosed as Parkinson's, right? And this is very frequent. Patients presenting mostly with bladder problems, with urinary problems, they usually go to the primary doctor who refers them to the urologist, and the urologist, of course, is used to the most common problems, like prostate problems, and it's not uncommon that patients with MSA early undergo prostate surgery, which is useless. I mean, in patients with MSA, it can even make things worse in terms of bladder symptoms, right? And this is unfortunately very common. Then you have patients whose major problem at the beginning can be the blood pressure problems, right? When they stand up, the blood pressure drops, not enough blood is arriving in the brain, and they can get dizzy, lightheaded, and sometimes they can faint, pass out. And there will be a comprehensive talk about NOH, so I'm not going to talk too much about this, right? But so the manifestations are so diverse. Blood pressure problems, bladder problems. Men can also have erectile dysfunction. They can have these Parkinson's-like syndrome. They can have these other cerebellar syndrome who doctors can think of, oh, is this patient drinking a lot of alcohol? What's going on here? So it may take a few years to diagnose MSA from the time that the disease starts. And this is what we call a diagnostic delay, right? So it's usually, and this is reports from the GLOMSAR survey, which some of you completed. This is a survey, and Lucy may talk about a little bit more about this in the future. This is a survey which is supported by the MSA Coalition, where we answer by patients with MSA, right? And when we ask them, how long did it take for your doctors to diagnose the disease? The average delay was 3.5 years, right? Which, it's significant, I mean, being around for almost 4 years without a correct diagnosis is a problem, right? And then you have there it's a small graph, I apologize for that, but basically we ask patients what was the first thing that they thought, there's something wrong here, right? And almost 50% they said that the first symptom was trouble with movement or falling. So that's a movement problem, which can be either Parkinsonian or cerebellar. Then 28%, almost a third, said that the first problem was trouble with blood pressure or with urination. As I mentioned before, autonomic problems, which are a must to diagnose this disease. Then 16%, the first symptom was acting out in their dreams, which is this thing I was talking before called REM sleep behavior disorder. And then 7% were not sure or were not able to recall. But you can see how these variety of presentations can make diagnosis difficult for doctors who are not familiar with the disease, right? So let me give you a brief overview on how we treat patients with MSA. The first one is bad news, right? So we don't have anything that can slow or stop or revert the progression of the disease, meaning we don't have a cure. We don't have a cure. We are working on it. We are trying to find new molecules. We are having clinical trials. I'll talk about that in a few minutes. But unfortunately, there is nothing so far that can stop the progression of the disease. There is no, so far we don't have evidence on anything, okay? You may find tons of websites, you may find tons of Facebook websites, pages telling you that they can cure MSA. It's not true. Those are quacks, right? So I just want to make you aware of that if there was something to cure MSA, rest assured, I will be using it, right? So, but we can treat problems in MSA. We can treat many of these things I mentioned to you before to improve the quality of life of patients with MSA, to make their life better and to avoid complications, right? And this is very important as well. So for instance, patients with these Parkinson's-like problems, with tremors, with some gait problems, with rigidity, some patients with MSA can respond to the treatments we use for patients with Parkinson's disease. And the most commonly used is the levodopa or the Sinemet, right? So some patients with MSA can have some response to that, and we may use it. Most of patients, unfortunately, do not respond well to the levodopa. And remember, this is one of the inclusion criteria or the diagnostic criteria for problem MSA. Then we have blood pressure problems, neurogenic orthostatic hypotension. It can be treated, right? There are non-pharmacological measures. There are a number of approved treatments, midodrine, fludrocortisone, Northera, droxidopa. These medicines work in the majority of patients, right? There is a minority of patients who do not respond well to these medications, for which new potential drugs in clinical trial development may be useful. We talk about that. But in most patients, NOH can be treated. You have bladder dysfunction, right? So the problem in patients with MSA is that they retain urine in the bladder. The bladder doesn't work properly, so there is no proper voiding. There is no proper emptying of the urine. And for these, we don't have good medications, unfortunately, because the medications that we have to treat bladder problems are for the opposite problems. It's usually women with incontinence, with frequency. For these, we do have a lot of medications that can work, but not for the bladder retention. So many patients eventually require the use of catheters, right? It can be either intermittent catheters, or some patients eventually need to have a suprapubic catheter, which is a tiny little tube placed over the bladder, like a faucet, quote unquote, and they just that's connected to an outlet so that the bladder can be emptied properly. Again, none of these treatments are proven to slow the progression of the disease. These treatments are to make quality of life better for the patient. Constipation can be managed with a number of laxatives, with prescription drugs. Sleep problems can be managed with medications for insomnia, or CPAP or BiPAP, these type of masks that people with sleep apnea use. Not infrequently, patients with MSA have that problems. And then the swallowing problems, which can affect some patients, they can be managed with a number of interventions. Some people need liquid thickeners to make liquids less prone to be swallowed into the lungs. But a minority of patients eventually will require a little tube here, a tracheostomy, to make sure they don't swallow into the lungs and make sure they are breathing properly, right? None of these treatments are proven to slow the progression of the disease. And then we usually recommend physical therapy, speech therapy. Is this going to slow the progression of the disease? No, but at least it's going to make sure that it's going to ensure that the muscles are as fit as possible, that the patients are moving as much as they can, and this overall makes quality of life better. Some patients can have joint pain, muscle pain, and we have medications for that. And some patients obviously can be depressed. We have medications for that, right? So there are many things that we can treat in patients with MSA. It's just that there is nothing that can slow the progression of the disease so far.